Welcome to MedSimu Nursing Podcast. Today we're doing a deep dive into two really critical electrolyte imbalances. These are definitely need-to-knows for anyone prepping for the NCLEX, hyponatremia and hypernatremia.
Absolutely. Sodium is just so fundamental, isn't it? Fluid balance, nerves, muscles. Getting these imbalances right is key for patient care, not just the exam.
Exactly. So we'll unpack what they are, what causes them, how your patients might present, and crucially, what we do as nurses.
Sounds good. Where should we start? Hyponatremia.
Yeah, let's start there. So hyponatremia, that's when the serum sodium drops below 135 millieqi, right?
That's the number. And you can't really talk about sodium without talking about water. They're intrinsically linked.
Definitely. How does that fluid volume part play into causing hyponatremia?
Well, think about it. Sodium's the main solute outside our cells. So if you mess with the water balance, you mess with the sodium concentration, if you lose fluids but replace them only with plain water or hypotonic fluids, you dilute the sodium that's left.
Okay, so dilution is one way.
Right. Or, conversely, you could be in a state of fluid overload, just too much water overall, which, again, dilutes the sodium. And we also have to remember ADH antidiuretic hormone.
Ah, the hormone from the pituitary.
Exactly. It tells the kidneys how much water to hang on to. So if ADH is out of whack, like in SIADH, you hold on to too much water and boom, diluted sodium. It really highlights how fluid status is critical context.
That makes a lot of sense. So let's break down the main culprits. What causes that sodium to drop?
Okay, we can kind of group them. First, there's increased sodium excretion, losing too much sodium.
Like how?
Well, think excessive sweating diaphoresis. Also, certain diuretics make the kidneys dump sodium. Vomiting, diarrhea, wound drainage, especially GI drainage, those are big ones. And kidney disease itself, or conditions where you have decreased aldosterone secretion. Remember, aldosterone helps retain sodium.
Right, so if aldosterone's low, you lose sodium. Got it. What's the second category?
Second is simply inadequate sodium intake. This isn't usually the sole cause, but it contributes, especially in patients who are NPO nothing by mouth for a while, or on really strict low-salt diets.
Okay. And the third? You mentioned dilution earlier?
Yes. The third is dilution of serum sodium. This is a big category. Excessive intake of hypertonic fluids, like drinking tons of water or getting hypertonic IVs. Even hypotonic irrigation fluids can be absorbed.
Wow, okay.
Then there's renal failure, freshwater drowning where the body absorbs hypertonic water, SIADH, which we mentioned, syndrome of inappropriate ADH, even hyperglycemia, high blood sugar, and congestive heart failure can lead to relative dilution.
That's quite a list of potential causes. So when you're assessing your patient, what signs and symptoms should make you think, maybe this is hyponatremia?
It really depends on their fluid status, which is key. Let's start with cardiovascular. If they're normal volemic, normal fluid volume, you might see a rapid pulse, but blood pressure might be okay.
And if they're low on fluid, hypovolemic.
Then you'd expect more like a thready, weak, rapid pulse, definitely hypotension, and maybe flat neck veins. Signs of dehydration, basically.
Okay. And if they're overloaded, hypervolemic.
Then you might see a rapid bounding pulse, and blood pressure could be normal or even high, plus potentially signs of fluid overload elsewhere.
Right. What about other systems? Respiratory?
Respirations might become shallow and ineffective, but that's usually a later sign due to muscle weakness. If they are hypervolemic, though, you might hear crackles, pulmonary edema.
Okay. And neuromuscular.
Generalized muscle weakness is pretty common, especially in the arms and legs. You might find diminished deep tendon reflexes. Early on, you might notice muscle twitching, but later that progresses to just weakness.
And the brain. CNS effects.
Oh, definitely. Headache is common. You might see personality changes, confusion. It can progress to seizures and even coma in severe cases. It's a major concern.
Sounds like it. What about GI?
You might see increased GI motility, hyperactive bowel sounds, maybe nausea, cramping, diarrhea.
And renal. What are we looking for in terms of urine?
Output can vary, could be up or down, depending on the cause, but a key lab finding is often decreased urine-specific gravity. The urine is dilute because the body's trying to get rid of excess water or can't concentrate urine properly.
And skin.
Often dry mucous membranes.
So a wide range of signs. Once I suspect or confirm hypernatremia, what are the nursing priorities? What do we do?
First and foremost, ongoing monitoring is crucial. Keep a close eye on all those systems. Cardiovascular, respiratory, neuromuscular, cerebral, renal, GI. Constant reassessment.
Makes sense. What about specific treatments?
Well, if it's hyponatremia with a fluid deficit hypervolemia, then we'll likely be giving IV sodium chloride infusions to replace both sodium and volume.
Okay. And if it's fluid excess?
If it's hypervolemic hyponatremia, then maybe osmotic diuretics will be ordered to help pull off that excess water while being careful not to worsen the sodium level too quickly.
What about for SIADH?
For SIADH, specific medications that block ADH action might be used alongside fluid restriction usually.
And patient education?
Big role there. If appropriate for the cause, educating the patient on increasing oral sodium intake. It helps to give examples of high sodium foods.
Like what?
Things like bacon, butter, canned foods, cheese, hot dogs, ketchup, lunch meats, milk, mustard, lots of processed foods, snack foods, soy sauce, table salt, even many breads. Just making them aware.
That's a good practical list. Any other really critical points for intervention?
Yes, a really important one, lithium. If your patient is on lithium, hyponatremia is a major risk factor for lithium toxicity because the kidneys might retain more lithium when sodium is low.
Ah, so they're reabsorbing lithium along with sodium?
Kind of, yes. So you need very close monitoring of lithium levels in that situation. It's critical.
Vital point. Okay, that covers hyponatremia well. Let's switch gears now and talk about the opposite. Hypernatremia, what's the definition there?
Hypernatremia is when the serum sodium level goes above 145 milliQL.
Okay, and what pushes the sodium level that high? What are the common causes?
Again, we can group them. First, decreased sodium excretion. The body is holding onto too much sodium.
What causes that?
This can happen with corticosteroid use, conditions like Cushing syndrome where you have excess corticosteroids naturally, renal failure sometimes, and hyperaldosteronism, too much aldosterone telling the kidneys to keep sodium.
Okay, so holding on to too much sodium. What else?
Second, increased sodium intake. Pretty straightforward, either eating way too much salt or getting excessive amounts of sodium-containing IV fluids.
Right.
Third is decreased water intake. This is a big risk for patients who are NPO or maybe unconscious or unable to access water for some reason. They become dehydrated and the sodium gets concentrated.
That makes sense.
And fourth is increased water loss, losing more water than sodium. This happens with things like a high metabolic rate, fever, hyperventilation, infections, excessive sweating again, really watery diarrhea, and a condition called diabetes insipidus.
Diabetes insipidus. That's related to ADH too, right?
Yeah.
But the opposite of SIADH.
Exactly. With diabetes insipidus, you have a deficiency of ADH or the kidneys don't respond to it, so you lose massive amounts of dilute urine, just pure water loss, essentially, leaving sodium behind and concentrated.
So again, it's about that balance between sodium and water.
Got it. Now, assessment for hypernatremia. What are we looking for? Cardiovascular signs.
Like with hyponatremia, the heart rate and BP often reflect the fluid volume status. You might see a rapid pulse if they're normovolemic or hypovolemic. If they happen to be hypervolemic with high sodium, maybe a rapid bounding pulse.
Any specific respiratory signs?
Not usually directly linked to the high sodium itself.
Okay. Neuromuscular.
Early on, you might see muscle twitching, maybe irregular contractions, but as it worsens, it typically progresses to skeletal muscle weakness and diminished or even absent deep tendon reflexes.
And the CNS, you said that was key in hyponatremia too.
Absolutely critical in hypernatremia as well. Altered cerebral function is really the hallmark. What you see might depend a bit on fluid status again.
How so? In patients who are normovolemic or hypovolemic, you might see more agitation, confusion, maybe seizures. If they're hypervolemic, it might present more as lethargy, stupor, or even coma. But across the board, a major symptom is extreme thirst.
Ah, that makes sense. The body is screaming for water.
Precisely. So GI-wise, that extreme thirst is the main thing.
Renal signs.
Urine. Again, output can vary depending on the cause. Like in DI, output is huge. But often, if the cause is dehydration, the kidneys try to compensate. So you'll see increased urine-specific gravity, very concentrated urine as the body desperately tries to hold on to water.
And skin and mucous membranes.
You'd expect to see dry, maybe flushed skin. Dry, sticky tongue and mucous membranes are classic signs. Edema might be present or absent depending on the overall fluid situation.
Okay, so we recognize the signs. What are the nursing interventions for hypernatremia?
Again, vigilant monitoring is paramount. Cardiovascular, respiratory, neuromuscular, cerebral, renal, integumentary, track everything closely.
And specific treatments.
If the cause is primarily fluid loss, then fluid replacement is key. Usually with IV fluids, often hypotonic or isotonic solutions, given carefully to avoid lowering the sodium too quickly.
Right. Correcting too fast can be dangerous for the brain too, can't it?
Absolutely. Slow, controlled correction is essential. Now, if the problem is impaired sodium excretion by the kidneys, then diuretics that promote sodium loss might be ordered like loop diuretics.
Okay. What about intake restrictions?
Yes, restricting sodium intake is usually necessary. We'd educate the patient again about those high sodium foods to avoid. And sometimes, depending on the situation and fluid status, fluid intake might also be restricted, though often fluid replacement is needed.
Anything else critical to monitor?
Definitely monitor potassium levels. Correcting sodium and fluid imbalances can cause shifts in potassium, and potassium imbalances, as you know, can lead to dangerous cardiac arrhythmias. So keep a close eye on the potassium, too.
So it sounds like, similar to hyponatremia, it's about careful monitoring, identifying the root cause, too much sodium in, not enough sodium out, or too little water, and tailoring the intervention, whether it's fluids, diuretics, or restrictions.
You've got it. It's all about restoring that balance safely and effectively based on the underlying problem.
All right, great. Let's do a quick 1-minute wrap-up for everyone tuning in, especially those studying for the NCLEX. We've just tackled 2 major electrolyte imbalances. Hyponatremia, which is sodium below 135, and hypernatremia, sodium above 145. We emphasized how closely tied sodium is to fluid balance and how imbalances can stem from issues with sodium excretion, sodium intake, or very commonly, water balance, either too much water diluting the sodium or too little water concentrating it.
Right.
We walked through the key causes for each, like diuretics, GI losses, SIADH for hyponatremia, and things like dehydration, diabetes insipidus, or excess sodium intake for hypernatremia.
Don't forget the assessment findings.
Absolutely. We covered the assessment findings, remembering that neuro changes are significant in both, but also looking at cardiovascular signs, which depend heavily on fluid status, plus neuromuscular, GI, renal, and skin changes. Thirst is a big one for hypernatremia.
Very true.
And finally, nursing interventions. Always start with close monitoring of all systems. For hyponatremia, interventions might involve sodium replacement if needed, fluid restriction or diuretics if overloaded, and specific meds for SIADH. For hypernatremia, it's often about careful fluid replacement, diuretics to help excrete sodium if needed, and sodium restriction. And in both cases, watching electrolytes like potassium is vital.
And that patient education piece is always important, too.
Definitely. So mastering these concepts, causes, assessment, interventions is fundamental not just for the exam, but for safe patient care every day.
Couldn't agree more. Keep reviewing these. Understand the why behind the signs and treatments.
Well, that wraps up our deep dive on sodium imbalances for today. We hope this has helped clarify these crucial topics for you.
Keep up the great work with your studies.
And be sure to join us next time on MedSmooth Nursing Podcast as we continue unpacking essential knowledge for your nursing journey.